Hormonal factors. Breast cancer in many women is related to the female predisposing hormone, reproductive hormone, particularly estrogen. An early age at menarche, nulliparity, late age at first full term pregnancy, late age at menopause increase the risk for developing breast cancer. And in postmenopausal women, obesity and postmenopausal hormone replacement therapy both associated with an elevated plasma estrogen level and plasma estradiol level and increased breast cancer risk. Most hormonal risk factors have a relative risk of less than 2 equal to 2 for breast cancer development, and the substantial evidence that estrogen deprivation via iatrogenic premature menopause can reduce breast cancer risk. Premenopausal women who undergo oophorectomy without hormone replacement have a markedly reduced risk of breast cancer later in life, with an increasing magnitude of risk reduction as the age at oophorectomy decreases. In women with BRCA1 and BRCA2 mutation, early oophorectomy lowers the risk of cancer risk. Total duration of total exposure to endogenous estrogen seems important. Early age at menarche and establishment of a regular ovulatory cycle, they are strongly linked to breast cancer risk. 20% decrease in the breast cancer risk for each year that menarche is delayed. The relationship between the pregnancy and breast cancer risk appears more complicated. Nulliparous women are at greater risk of development of breast cancer than parous women, while women whose first full-term pregnancy occurs after the age of 30 years have 2 to 5 fold increase in risk of breast cancer in comparison to women who have full-term first pregnancy before the age of 18 years. And breast cancer risk increases transiently for 10 years after the pregnancy but then declines. Breast cancer increases transiently for 10 years after a pregnancy but then declines. An abortion, whether spontaneous or induced, does not increase the risk of breast cancer. Breastfeeding, particularly for longer duration, lowers the risk of breast cancer diagnosis. Combined effects of reproductive history and breastfeeding account for substantial fraction of the difference in breast cancer risk between the high income and low income nations. Use of combined estrogen and progesterone HRT also increases the breast cancer risk. In Women's Health Initiative study, the use of combined estrogen and progesterone hormone replacement therapy was associated with 25% increase in the breast cancer development. An excess of abnormal mammogram was observed after 1 year of HRT use and persisted throughout the study. An increase in the breast cancer incidence was noted after 2 years. The cancers occurring in HRT users were larger and more likely to have a nodal or distant metastasis than those occurring in the placebo group, although they were of similar history and grade. Observational UK million women study found the concurrent use of HRT was associated with a relative risk of breast cancer development by 1.66 and relative risk of breast cancer death by 1.22. Dietary and lifestyle factors. While observational studies linked high fat diet with a higher rate of breast cancer than low fat diet, meta-analysis of 8 prospective epidemiological studies failed to identify an association between the fat intake and breast cancer risk in adult women. Randomized dietary modification in 48,000 women in Women's Health Initiative study did not result in a statistically significant reduction in the breast cancer incidence. Breast cancer risk increases linearly with the amount of alcohol consumption. Decreased intake of nutrients such as vitamin C, folate, beta carotene may enhance the risk of development related alcohol consumption. Obesity is associated with both increased risk of breast cancer development in postmenopausal and breast cancer mortality. Women with a BMI of more than 31 have 2.5 fold increased risk of developing breast cancer than those with a BMI of less than 22. Weight and weight gain appears to play an important but complex role in breast cancer risk. During childhood, Rapid growth rate decreases the age of menarche, an established risk factor, and results in a greater attained stature, which has been loosely consistently associated with an increased risk. And during early adult life, obesity is associated with a lower incidence of breast cancer before menopause, but no reduction in breast cancer mortality. Weight gain after the age of 18 years is associated with a graded and substantial increase in the postmenopausal breast cancer, particularly in absence of HRT. Benign breast disease. Benign breast lesions are classified as proliferative or non-proliferative. Non-proliferative disease is not associated with an increased risk of breast cancer. Proliferative, this is without atypia, have a small increased risk, relative risk of 1.5 to 2, and whereas proliferative with atypical hypoplasia is associated with a greater 4 to 5 relative risk of breast cancer. So proliferative breast cancer appears to be more common in women with a family history of breast cancer than in control, supporting its significance as a risk factor. And however, the majority of breast biopsies done for clinical indications demonstrate non-proliferative disease. And in a study of 10,000 breast cancers, 69% had a non-proliferative changes. Only 3.6% demonstrate atypical hypoplasia. Lobular carcinoma in situ is a benign breast lesion that confers a elevated subsequent risk, a relative risk of 8 to 10. And the risk was historically thought to be conferred equally into both breasts, yet contemporary studies demonstrate that approximately two-thirds of the subsequent malignancies occur in the ipsilateral breast, and this does not seem to significant interaction between the family history and the breast cancer and risk imparted by lobular carcinoma in situ. A recent analysis suggests an increased breast cancer density that further increases the risk of among women with this lobular carcinoma in situ. So breast density, mammographic breast density is a predictor of breast cancer risk and makes screening detection of cancer more difficult. And a significant components of breast density is generally determined, and although density has also been shown to vary with initiation and discontinuation of postmenopausal HRT, women with more than 75% of the breast density have a 4.7 fold increase in the odds of breast cancer development compared to those with less than 10% of the breast density. Environmental factors like ionizing radiation, particularly at the age less than 30 years, increase their cancer risk. The pattern has been observed in survivors of the atomic bombing and those undergoing multiple X-ray examination and women receiving therapeutic irradiation of the chest. Increased risk of breast cancer development has been reported in women who receive mental irradiation for the development of treatment of Hodgkin's lymphoma before the age of 30 years. The risk of a second contralateral cancer in patients approximate the level of risk in seen in BRCA mutation career. Exposure to electromagnetic field or organochlorine pesticide does not increase the breast cancer risk. So magnitude of risk of known breast cancer, relative risk less than 2, 2 to 4, more than 4. Less than 2 is early menarche, late menopause, nulliparity, estrogen plus progesterone, OCPs, HRT, alcohol, and postmenopausal obesity. They have a relative risk low. Intermediate 2 to 4 is seen when first degree relative with the breast cancer. CHEK2 mutation, older age 35 years and first childbirth. Proliferative breast disease and mammographic breast density. So first degree relative with the breast cancer, CHEK2 mutation, first child after age 35, proliferative breast disease and mammographic breast density. And relative risk of more than 4 is seen with BRCA1, BRCA2 mutation in PAL-B2, and lobular carcinoma in situ is also relative risk more. Atypical hypoplasia and radiation exposure before the age of 30 years. Thank you.